Welcome everybody to this beautiful afternoon. A little bit warmer in here than what it is outside. I guess it's supposed to be getting warmer through the weekend. Just thank you very much for coming, and hopefully we can give you some information regarding hip and knee replacement surgeries that'll give you some benefits and we'll have a time at the end of the discussion for questions. And so I'll go through the discussion right now, but then we'll talk about it some more. And I've got some models of some joints here we can look at the end too for anybody who's interested. So I appreciate you all attending. That's great. So my job as an orthopedic surgeon is to keep people active. I'm not expecting to turn you into Olympic athletes, as this gentleman is. But again, we want to keep people doing the things that they want to do. And unfortunately, arthritis interrupts people's lifestyles so dramatically that you have to go through certain means of being able to get through all of that and get back to normal lifestyles. So just for some history, I've been doing this for about 35 years now, so I guess I'm one of the oldest guys here doing it. My university education, I started off actually as a chemical engineer, and then I went and did postgraduate medical engineering in England, which led me to the interest in the medical field. Came back to North America and did medical school, followed by orthopedics and training in orthopedics, which really fits hand in hand with engineering. So I'm a human engineer as opposed to a guy that works on transmissions, as we saw a gentleman this morning.
40 years.
There you go. So we'll talk about these different things. Who's a candidate for joint replacement? We'll talk about some patients that have gone through this, some facts and figures about osteoarthritis, some myths that always are complicating things for people as to who needs what. And then we'll talk about the implants themselves, and then we'll open it up for questions at the end. So again, all of you are here because you either suffer from some form of arthritis or know people that do. And again, you can see how it affects their lifestyles on a daily basis. So how many of these people are suffering through the pain, giving up on their quality of life? They can't do the things that they used to be able to do. And just having undergone surgery myself 6 weeks ago on my knee and having to use crutches for a short period of time and being able to equate with this, it certainly is a frustrating situation. And you want to do something as quickly as possible to try to fix that situation. So here's some interesting points. And some just typical initial diagnostic questions that we ask all the time when people come into the office. How severe is the pain? How many days per week do you feel that pain? Is it on a daily basis? Most importantly, does it interfere with your sleep pattern? And that's what usually puts people over the edge. When they can't get a good night's sleep at night and they're tossing and turning, or every time they roll over in bed, their knee or hip wakes them up, that's what oftentimes will bring them to the doctor. Is it possible to keep on doing what you do on a daily routine? Do you have to miss work? Does it prevent you from doing the hobbies that you like to do? And because of your inactivity, have you gained weight because of it? All very important questions. So questions we should ask, if you had resolution of that, would you be much happier? Could you do more things and be happier in your lifestyle? So what would you be able to do? And could you get back to playing golf? Could you get back to following your wife through Walmart? Could you get back to going to the movies? All those things that are important to do, that are very important to our daily lifestyles. So again, very clear, how can this improve your quality of life? So just as an example, here's a typical person, a person who's undergone a knee replacement, back to normal activities, being able to do the things that she likes to do. A dairy farmer, tennis player, couldn't do the things she wanted to do, couldn't be active. And she also noticed that her personality was changing. That's often very, very important, that people aren't as happy-go-lucky, they don't come in, they don't have that smile on their face. Things just aren't the way they used to be. Again, another example of a relatively young gentleman. Couldn't be a basketball referee, couldn't coach tennis, and wasn't willing to live his lifestyle that way, wanted to change to be able to get back to doing the things that he loved. Again, very active, even out in the field all the time, out in the forest, a runner. And again, as I can attest to, you get anxious, you feel a sense of helplessness that you can't be the person you used to be. Somebody who's on their feet all day long, people that ride their horses, again, play tennis, play golf, things that they can't do anymore. Being able to have these things fixed certainly improves their quality of life and lifestyle. So arthritis facts, and this is a shoulder x-ray actually. And if you look right here, that's the ball and that's the socket. And the arthritis basically erodes or interferes with all the surface coating that covers over the bone. So instead of having a very smooth surface rubbing on a smooth surface, you have bone rubbing against bone. Not only is it painful on activities, but again, even at rest, it can be extremely painful. So it's almost an epidemic through the world, basically. And you can see these figures. I mean, 25 million people have arthritis attributable activity limitation. They can't do the things they want to do. Again, and there's different forms of arthritis, but osteoarthritis, which is the wearing down of the surfaces inside the joint, is the most common. People also have heard of rheumatoid arthritis. There's a handful of different types of arthritis complications and problems, but osteoarthritis is the one that's most affected. So again, caused by cartilage breakdown, is that a very smooth surface that covers all joints. Even your baby finger has little articular cartilage that covers all the joints that allows one bone to move smoothly on the other bone. And when you have bone rubbing against bone, it's very, very painful. It causes swelling, causes insecurity sensations, and even causes nighttime discomfort. Once that's happened, the joint changes are irreversible. Once you've worn that out, there's nothing you can do that's going to make that come back. And oftentimes it's undiagnosed until it's progressed to the point where you're so symptomatic that you are forced into certain situations that you'd rather not be in. So joint replacement is one option to go ahead and fix that. There are other things we'll talk about in a few minutes that predate the actual surgery, and there are ways of being able to try to put off surgery for as long as possible. We'll discuss that in a minute. The other thing that it's important to know is that, of course, as we get older, age has a significant issue with regards to the development of arthritis. Weight also a significant concern. And there's a correlation with diabetes. People that are diabetic have a tendency to have more arthritis than non-diabetics. And the comment made here on the slide is that 52% of adults with diabetes have some form of arthritis. And as we get older, that number increases. So treatment, how do we go ahead and treat arthritis? Well, by patient education, people have to be aware of what the actual diagnosis is. Self-management programs, you can take Advil or Aleve or other medications, Tylenol, to try and reduce the discomfort. Joint protection and energy conservation, meaning you try to modify your activities. So if it hurt to run, well, you don't run anymore. If it hurt to play golf, you don't play golf anymore. Physical therapy can be advantageous to strengthen the muscles around the joint, and that can give you more power and more comfort. Yeah, assisted devices, clearly people sometimes go to using a cane or a crutch or a walker just to try and take some of the weight off the leg. And weight loss, which is a very difficult thing to achieve when you have arthritis, certainly helps by reducing the amount of stress. Then there's medications. As I mentioned, you can take something as simple as Tylenol. There's topical medications you can buy over the counter to put on your knee, and there's newer medications you can get prescriptions for that have anti-inflammatory and analgesic qualities to them. You can rub on the joint. There's anti-inflammatory prescription medications. COX-2, for example, Celebrex, people have heard of that medication. There's a whole host of different medications, some that are generic, some that are not. And by reducing inflammation in the body, it helps to reduce inflammation in the joint. You can have an injection in the joint. Cortisone shots are the most common. And this other medication, the hyaluronan, is a lubricating injection you can have put in the joint. It's been FDA approved for knees only, but some people are using it in other joints as well, although that's off-label. But it's been cleared by the FDA for injections in the knee. There are 5 different companies that make that medication. The original medication is called Synvisc. That was a series of 3 injections 1 week apart. There are medications, one company makes a 5 injection series, and there's a group here in town that offers that, but that means going back to the doctor once a week for 5 weeks for injections. That's clearly no fun to have a needle stuck in your knee 5 weeks in a row. The original injection, the Synvisc, it's been approved for a single injection, so they combined all 3 into one, and you come to the office and have 1 injection put in. Tramadol is just a pain medication. It has a little anti-inflammatory quality to it. And then, of course, there are stronger medications if necessary. And again, to try to defeat the pain. When it comes to surgical intervention, there's the options, if it's very early, of just cleaning the knee joint out. That doesn't work so well, but some people go for that. Osteotomy is a means of being able to alter the angle of the joint, done primarily in knees in young people that have a significant deformity. So if they're really bow-legged or very knock-kneed, then you can do what's called an osteotomy. It's somewhat complicated, but you change the direction of the force through the joint. So you move the stress from one side of the joint that is significantly arthritic to the opposite side to try to relieve some pain and buy more time. And then, of course, what we're here to talk about today basically is total joint arthroplasty, which means to cover all the arthritis in the joint and get rid of it, to get rid of that knee pain. There's a lot of discussion about when you should have this done. There are some people that suggest that you should wait as long as possible, and that's often what's done. People just, when they see the doctor says, when you can't stand it anymore, come on back and we'll talk about doing a joint replacement. There are some studies to suggest that if you do it earlier than that, then you haven't got as much muscle wasting and weakness around the extremity, and you can enjoy many more years of normal lifestyle if you have it done earlier. But I think it really is patient dependent. I think a lot of it has to do with the patient feeling comfortable with the concept. Clearly the proper diagnosis has to be made, and if you see the right physician, they can give you all the different options that are available to you to try to resolve that situation. And if you get to a point where you've failed all the conservative treatments and you say enough is enough, then that's probably the right time to go ahead and have the joint fixed. So here's some myths about joint replacement, and we'll go through each one of these. So myth 1, patients who have arthritis pain should only consider conservative treatment options. Well, we sort of alluded to that in the last discussion. So conservative treatments can lessen pain and may prolong limited function. So if you have restricted range of motion in your knee, it's stiff. I mean, you can get maybe some pain relief, but you still may have that significant stiffness in your knee. If you have that knee fixed, you can not only get rid of your knee pain, but you can also enjoy much improved range of motion in your knee too. So myth 2, joints won't feel natural if it's replaced. And the advances in knee replacements and hip replacements are so dramatic over the last number of years that most people are so happy when they have it done that after a period of time they almost forget about the fact that they have it inside their joint. It actually does feel quite normal. And again, we'll talk about some of the different options in joint replacement, especially knees with rotating platforms and the new implants that are available, that patients regain their range of motion very quickly and feel very, very comfortable with them. Myth number 3, many of my patients are too young for total joint replacement. Now, years ago, when I first started out in this business, you had to be almost 65 or older to have a joint replacement. But nowadays, it's a matter of quality of life issue. And I see people actually down into their 20s and 30s that have some form of arthritis which has basically destroyed their joint. And the option is to let them wait 40 years of being miserable before they do a joint replacement, or go ahead and fix them. And so now with the newer implants, the newer technology, the new techniques, I do it oftentimes in people much younger. So it's not that uncommon. It's much more common for people that are older, of course, but not uncommon to have somebody in their mid-30s or 40s to have a joint replacement surgery done. Again, quality of life issue. Again, number 4, we talked about that briefly. My patients should wait as long as possible to get a joint replacement. I think it boils down to the individual. When you're tired of your knee or your hip hurting, you say enough is enough, and you qualify for it clinically and radiologically, then I think it's reasonable to go ahead and consider having it fixed. And all joint replacements are the same. That's an absolute myth. And we can talk about this till the cows come home. A number of years ago, there used to be one company that put out a special knee for women, for example. And that's all been basically put to rest. All the newer companies, all the new joints, they all basically fit joints that, for the anatomy that they have to replace. So that's very, very important. So, and we'll get into the technology now in a few minutes as well about how we do knee replacements. Basically, it fits exactly to the conformity of the knee. So let's talk about hips first. So the hip anatomy on the left, that's a normal hip. So basically it's a ball inside a socket, and covering the ball is a very smooth white surface, kind of a yellowish color in this or pinkish color in the slide, but it's pure white. And the same thing on the socket, you can't see inside, but it's pure white as well. So if you look at, for example, a chicken leg, a fresh chicken leg as an example, Now, before you cook it, if you look at the ball of the chicken leg, it's pearly white. Next time, take a little razor and shave off that white surface coating over top of that ball. Below that is the actual bone. And arthritis is basically the wearing off of that pearly white surface coating over the ball. And so when you have that, that's what arthritis looks like. So you've lost that very smooth surface that articulates on the opposite surface. And you end up with bone rubbing against bone. And that's what causes the creaking, the grinding, the pain, and the restricted range of motion. So when you go ahead and replace it, basically, you're putting a brand new liner inside here. And the way the technology is now, there's a metal shell that goes inside the socket, and you put a plastic liner that goes inside that metal shell. Then there's a ball that may be made up of different types of materials, ceramic, for example, on this one, and then a stem that goes down inside the canal of the marrow, and that's what holds it in place. And that basically is a hip replacement. There are different approaches to the way you get to the hip. You can go through the back of the hip, the side of the hip, or the front of the hip. The most common one is what's called the posterior approach, and we'll discuss that in a second. There's an example right there. Depending on the individual and the size of the individual, the smaller the person, the smaller the incision, and you can oftentimes make that in a 4 to 5 inch incision to go ahead and put that hip in. People that are a little on the larger size that need a larger incision, it could be up to 12 inches in length. What's hit the airwaves an awful lot and what people hear about and read about is what's called the anterior approach. And it really isn't so much the approach that you use, it's basically who does the approach. So again, there's an anterior approach in the front and a posterior approach from behind. And if you really go to all the, as I go to all the orthopedic meetings, it's pretty much a marketing thing nowadays to consider that the anterior approach is a better approach than the posterior approach. Again, it's a matter of who feels comfortable doing what approach and being able to get into the hip joint and cover it with the implant that we just described. Lots of different technologies, all different kinds of implants. That all has to be chosen for the right individual, and there's ways of being able to select the actual implant that you want. So these are various implants made by this company that can be used in hip replacements, and they're all made up of different materials, but primarily space-age materials that have titanium in them. And most of them have, if you look at this, sort of a porous coating on this implant, as opposed to this one that's very, very sleek and shiny. These have implant surfaces that actually, when you put these into the bone actually grows into it. It's almost like a fracture healing. The bone grows into the implant. Years ago, they used to put cement, this special kind of cement, into the bone and then push the implant into the cement and have it lock in place. They found that over the course of years that cement would loosen and the implant would loosen and it had to be revised. With these newer implants over the last number of years, the bone grows in and it becomes part of you. On the socket side, all different kinds, again, of different options available. You can put a metal ball inside a plastic liner that's inside that metal shell. There's ceramic as well, and now they're making some ceramic balls and ceramic liners. If you go on YouTube and put on ceramic, you'll hear, it's kind of funny sometimes, not really that funny, but sometimes they squeak. So you'll see people going up and down stairs and you'll hear them squeaking. And nothing's wrong with the implant, it's just the noise that's emanated from the ceramic rubbing on the ceramic. And the newer ceramics are not having that issue as much as the original ones. They've even improved on that too. Again, they do all kinds of studies on these things and watch them very, very carefully. So they do these things where they watch them for 9 or 10 years. And here's an example where this socket and implant construct at 9 years, 96% of them are still functioning fine. That's a pretty high success rate. Years ago, success rates weren't quite as high, but again, the technology, the new materials, it's fascinating how well these work and how long they work for. Nowadays, one would expect, especially for somebody who's 60 years of age and older, if you go ahead and put a new hip in, one would expect that hip to last a lifetime. It's really unlikely that that's going to wear out. Again, another study showing a 98.6% survivorship or lasting effect of that implant. And again, they look at all the different data to make sure that the materials that they're using, which improve always, shows that the wear patterns, the likelihood of it wearing out is extremely small. Again, it's actually up to the physician, of course, to choose which bearing he wants. It's interesting how some people will read up on us on the internet and they'll come in to me and they'll say, I need my hip replacement, and they'll actually list off the things that they want. We try to comply, but basically it depends on what they really truly need. A lot of it depends on their age, their lifestyle, how much they weigh, their age, how bad their disease is, and how good their bone is as well. Potential benefits, as we talked about, you get the diseased anatomy. The arthritis is completely replaced by the implant, so no more arthritis. And once that implant is in there, you can never have arthritis back in that joint again. It's done. Significant pain relief, improved mobility, increased range of motion, and of course, trying to get back to a lifestyle that you're happy with. As with any surgery, there's always potential complications, and although they're very rare, there's always the potential for a dislocation of a hip. There's nerves and arteries in the area that you have to be very careful to protect against. There's always a chance of an implant fracture, but I haven't seen that in 20 years. Infection's always a big deal, especially in diabetics. We're always worried about that and do all kinds of things to protect people from that. Even afterwards, for years afterwards, if people go to the dentist and have dental work done, we ask them to take antibiotics beforehand to make sure that they don't get an infection just from working on somebody's tooth. Corrosion, again, of the implant, very rare now with the newer materials. And this debris, that again, very rare as well. So again, a lot of this depends on the individual as to whether they go through this and whether they've failed their conservative management and it's time for them to have the surgery done. So those are just important things: age and weight, the activity level before surgery, overall general health. For people that have medical concerns, we always have them checked out by their internist or their cardiologist or their family doctor to make sure they qualify medically for the operation. That's very, very mandatory. And also we need to know about the patient's attitude. We try to be cheerleaders for the patients and get them back to their lifestyle as quickly as possible, get them into physical therapy, whether it's at the house short term or whether it's in physical therapy afterwards. So the routine basically for a hip replacement, the way things work nowadays, people, once they're scheduled for the surgery, they would come in for the operation, the day of the operation. If you get it done early enough in the day, you can literally get up and walk on it that day. Most of our total hips and total knees, for that matter, are going home within 24 to 36 hours of the operation now. When they go home, the home health nurses and the physical therapists come to the house, and they continue to monitor the incision. They do physical therapy at the house. By the time they come back to see me at the 3-week mark following surgery, half of them are off their walker or crutches and onto a cane. So a very fast recovery, much faster than it used to be. It still takes months for you to get really used to your new joint. It takes a long time to regain all the strength that you've lost in that muscle over the course of time. And one thing I need to point out, there's been a breakthrough over the last year and a half. There's a new medication that we use at the time of surgery. It's called Exparel. It's an injection that you inject around the joint, and we do it in hips and knees. It's like a long-acting Novocaine. So when you go to the dentist and having a tooth fixed, and they inject Novocaine into the gum area, and it freezes the tooth, allows them to do that, this medication is very similar, but it lasts for 36 hours typically. So when you inject it all around the joint, then it gives an awful lot of pain relief right off the bat. So the pain that people had when they had their joint replacement surgeries in years past, a lot of that is not present now for at least 3 days. And so by the time 3 days rolls around, the pain that you have inside your joint from the surgery is dramatically less than it would have been day 1 or day 2 or day 3. So it makes the recovery that much more comfortable. People get up and walk around on them very, very fast. They regain their range of motion very quickly, especially on knees. Not so much an important factor with hips. And so it makes the recovery that much better. People that I've operated on, that I've done both sides, one hip, for example, 10 years ago, and the other hip just a year ago, can't believe the difference between the two, like night and day. So we'll go quickly on to knees now. Again, knee anatomy on the left is a normal knee. The knee is made up basically of the thigh bone above, the femur, the tibia or shin bone down below, and the kneecap in the front. So there's basically 3 compartments to the knee. There's the inside compartment between the femur and the tibia, the outside compartment, the same femur and tibia, and then the kneecap compartment in the front. So 3 compartments. And it's possible to have arthritis generally through all 3, as it shows on this slide right here. It's possible to have arthritis just in one compartment, and we'll discuss that options when that is the case. When it comes to a knee replacement surgery, there's an implant that covers over the end of the thigh bone. There's an implant that covers on the top of the shin bone, and a plastic wafer that goes in between the two. Again, just like in hips, a lot of advances with the materials, and there's different types of implants, a whole assortment that are available. There's one that's called a fixed bearing, where the plastic is locked in to that metal tray and this rotating platform. And we have examples here we can show you after the seminar, where actually the plastic rotates inside. So again, just with hips, you know, what could a knee replacement do that you couldn't do before? Here's a gentleman that can, you know, get back into playing handball, whereas he couldn't obviously with arthritis in his knee. The new breakthrough with this company is a knee implant called the Attune, and the materials of this are phenomenal. The design is exactly the design that needs to be to fit somebody's knee. The contours are very, very good, and it comes in this fixed bearing, which is up here, or a rotating platform down here, to allow people to regain range of motion very, very quickly. This knee feels extremely natural. When you put this knee in and people are up on it, typically even within 3 weeks when they come back, they see a dramatic improvement in their function, their range of motion is dramatic, and they really feel the knee feels almost like their own knee. Again, this is some of the design work to try to make sure that this Attune fit exactly as it needed to be to fit the contours of a knee joint. Again, it feels much more stable, and you feel like you're back on your feet much faster. So one of the things that was interesting is when physical therapists saw these patients that came back with this new knee, they didn't know that the components had changed from the previous design to this. And they were all startled to see that they were wondering why the Attune knees were feeling so much more natural and how they were regaining their range of motion so much more quickly. So even the physical therapist could see a dramatic improvement. Again, lots of research, millions of dollars in funding to go ahead and get this designed. I went up to actually the company where they made these things and saw how this went through, and it's pretty impressive. So here's just attestation. Don't put off conservative treatment for too long. Try to get back and get to your normal lifestyle as quickly as possible by this person. Again, pleased with his knee replacement. Can go through great range of motion, get the knee fully extended, which you couldn't do before, and then obviously back into sports activities as well. Again, just as with hip, somebody now doing work around the house they couldn't do before, couldn't climb a ladder before because of the arthritis in their knee. So again, this is the implant that was used before. I've used this for many years, have great results, and lots of people with this that are extremely happy with it. It's called a fixed bearing knee. Again, this plastic is locked into the tray. It doesn't rotate, but for people that are not as active, it does a phenomenal job, and they don't have to have that rotation. Again, fixed bearing and then rotating platform. That's the rotating platform. And again, if you see the example here, you'll see what the difference is. But basically, this plastic rotates around, so it really tries to recreate what a normal knee does. Again, 20 years, 97% of patients still depend on the rotating platform. So extremely high survival rate. These things are working for many, many years. Now, as I mentioned to you, it's possible to have arthritis just in one compartment. And if you do, then it's feasible that instead of having the entire knee covered, then it's possible to go ahead and just cover one part of the knee. So here's a typical uni compartment replacement or partial knee replacement. Again, you just go ahead and replace the inside part of the knee that covers over the end of the thigh bone. There's a small plate that covers on the inside part of the shin bone and the plastic liner that goes between the two. I'll go back on this slide for a second if I can. So the latest technology, which is really, really interesting, is called TRUMATCH from this company. And so what they do on a TRUMATCH, when you come to see me, we send you downstairs for a CAT scan. The CAT scan is done of the entire extremity. It goes from the hip to the knee to the ankle. The CAT scan is then sent wirelessly up to the company, DePuy, that makes the knee. They do 3D imaging of the knee based on the CAT scan. So the CAT scan is a very fancy thing. It takes slices of the knee, front, back, side, top to bottom, and they can do 3D imaging of that knee. And then they send that down to me on my computer. And at nighttime, I operate on your knee on my computer at home. And I design exactly where that knee is going to go. So the knee is in perfect alignment with the extremity, and it's completely balanced. So I figure all that out, and then I send that back to the company, and then the company makes a mold of your knee based on my plan. And I'll show you what the molds look like. So they do the 3D imaging. And then they make these molds. So this is the mold here that goes on the end of the femur bone. And this is the mold that goes on the top of the shin bone. So when we do the surgery, basically we open up the knee, we expose the end of the femur bone and the top of the shin bone. we put this mold that fits directly onto the knee. So it wouldn't fit anybody else in the world but that bone. That's how accurate that is. And then there are 4 places to pin it. Here, here, and 2 little places here. You put these little pins that holds it in place. And that slot right there is where you go ahead and put a special saw that goes through, and it removes the arthritic surface off the end of the femur bone and then on the tibia bone right here. So it's exactly where the arthritis needs to be removed. And then simply go ahead and put the implant on the bones. So it's perfect. All the decision making for where that knee has to go has been made long before you even get to surgery. When we put the implant on, it fits so precisely on the knee, and then we go ahead and just close it up. It actually saves about a half an hour off the operation because all those decisions, all those things you had to think about before and decide where you're going to make those cuts before, that's all been done beforehand. So it shaves time off the operation, number 1. Number 2, the accuracy is phenomenal and allows people to get back. That's why we get the range of motion back so quickly. So that, in conjunction with that expiral drug we're injecting in around the joints, has made a huge game changer of an outcome to get people back doing the things they want to do. Again, just as with hips, you go ahead and replace the damaged surface with the implant. You get immediate pain relief from the arthritis. You still have discomfort, of course, from the operation, which you have to go through. But again, that expiral drug makes that a lot easier. Your mobility is improved dramatically with increased range of motion and function. Again, just as with hips, there's always the potential for complications, and you can't go into this blind. I mean, the risk of these things is extremely remote, very, very rare. So who should consider a knee replacement? Again, same thing with the hips. Age and weight, activity level before surgery, how your general health is, and all the other things as to what you need to go through to be able to make sure that you're going to do well with this joint replacement surgery and function well for many years to come. So again, it's not for everybody, but it certainly is for people that qualify for it. That decision's made by your physician, your orthopedic surgeon, and if you qualify for it and go through it and it's done properly, then you should do very, very well. Thank you.